A curious case of culture-negative Lemierre syndrome with empyema. Pharyngitis can uncommonly cause bacteremia, jugular venous thrombosis, and metastatic septic phenomena, classically termed Lemierre syndrome. Typical causative agent is an anaerobe, Fusobacterium necrophorum. We report a case of culture-negative Lemierre syndrome in a young male. A 28-year-old male presented with 1 week history of pain and stiffness in his right neck. His vital signs revealed tachycardia up to 110 beats per minute and elevated blood pressure of 160 by 81 millimeters of mercury, though he was afebrile with an oxygen saturation of 100% on room air. A tender non-erythematous swelling was found in his right neck. Labs revealed a white count of 25.37 and an ESR that was elevated more than 130 and CRP 344. CT of neck soft tissue revealed the right sternocleidomastoid abscess as demonstrated in Figure 1, with associated compression and thrombosis of the right internal jugular vein. Empiric antibiotics linezolid and piperacillin tazobactam along with methylprednisolone were initiated and ENT was consulted, and they performed an urgent incision and drainage of the neck abscess. Blood cultures and surgical cultures from that procedure showed no final growth. CT of the chest revealed a 5.1 by 2.7 centimeter collection in the right chest wall deep to the second rib, as demonstrated in Figure 2. Cardiothoracic surgery performed a video-assisted thoracoscopic VATS drainage of the chest wall abscess with chest tube placement. Cultures from the VATS procedure also revealed no final growth. However, next-generation sequencing of the IND operative specimen revealed Fusobacterium necrophorum. After several days, the patient's symptoms improved and the chest tube was removed. He was discharged home on 5 weeks of daily IV piperacillin tazobactam infusions at an infusion center. Lemierre syndrome is a rare condition characterized by pharyngitis followed by septic thrombophlebitis of the internal jugular vein and septic embolic vein implantation. Most commonly involved locations of septic emboli include the lungs and mediastinum, along with large joints, skin, and other distant organs. Fusobacterium necrophorum is the most frequently identified causative organism. In our case, regular aerobic and anaerobic culture techniques failed to identify a causative organism. However, a next-generation sequencing of the operative specimen resulted with Fusobacterium species. Prompt initiation of antimicrobials is required to prevent septic shock. Corticosteroids may help in preventing airway collapse. Definitive management, however, includes urgent drainage of the next abscess, although further drainage of distant septic implants may also be warranted, as in our case. Our case underscores the importance of considering Lemierre syndrome for all deep neck space infections associated with vascular thrombosis, and also it underscores the importance of initiating prompt surgical management and utilizing newer techniques such as next-generation sequencing for identification of microorganisms for targeted long-term therapy.